Good morning, everyone. Morning, everyone. I'd first of all like to extend my thanks very much to the TED Organising Committee here at SRM for providing me with this opportunity to stand in front of you today and to share with you some of my experiences. One of the things that you might already notice, the eagle-eyed amongst you, is that I'm English. I have a 22-year corporate career behind me back in the UK. And yet, I threw that all away and dragged my family 5,000 miles across the world to come to work as chief executive of an NGO in Chennai. And what I'd like to do today is share with you the story that inspired me to make that decision. Picture the scene, if you will. Many of you in the audience are from the student body, so this will be easier for some of you. For some of the rest of you, this might be casting your minds back a few years. Picture the scene. It's 1993, and two young girls are just leaving college at the end of a hard week. They've been studying really hard. Vandana, who's a student of social work, Vaishnavi, who's studying business, coming out of college, chatting away, as you would do. Two normal girls, healthy, happy, chatting about the weekend, what is it they're going to be doing, all of that kind of issue. They're walking through the streets and approaching a very busy main road. As they're walking, they spot, in the distance, a young woman, semi-naked, clearly deranged, wandering around in the middle of this traffic. Buses and trucks thundering past her, clearly in danger. Without a thought for their own safety, these two young girls dive into the middle of the traffic and rescue this woman to the relative safety of the pavement. How many of us would have even seen this young girl, let alone taken some action about it? But that, of course, was the start of their problems. What happened over the next few days is that Vandana and Vaishnavi discovered a crash course in what is wrong with the mental health service that is provided to most people across India. They made many calls to multiple agencies and discovered that no one was prepared to deal with this poor young woman that they just rescued. The combination of poverty, mental illness, and her being a woman meant that there was simply nowhere for her to go. So what did these two young girls do? They took her home. What else were they going to do? They took her home and started caring for her, and the seeds of the organisation that is now called the Banyan were formed. Now, just to put a little bit of context to this, mental health, according to the WHO, will affect 1 in 4 families. So across 200 population in this room, at least 50 of you will have a family member that suffers from a mental health problem. Across Asia, mental health is the second biggest contributor to disability. And yet, neither government, nor funding agencies, nor the general public prioritise the contributions that they could make, the donations they could make, towards this particular cause. What that means, of course, is for the Vandana and Vaishnavi, they found an uphill battle to raise resources if they were going to get their project off the ground. Now, of course, the fact that I'm standing here 17 years later shows that the battles were won, resources were raised, and the organisation was able to start functioning, which is fantastic. They started rescuing women. Yeah. Why did that go backwards? Yeah. They started rescuing women from the streets to a 3-bed house in the west of the city of Chennai. 3 beds, we figured, would be plenty big enough for the 25 or so cases we thought would come through the doors. Now, the way in which the Banyan operates is founded on a couple of key points. One is that we fundamentally believe that mental illness does not mean the end of a productive life. In fact, many conditions can be managed successfully and people can return to happy, normal, productive lives, provided they have the right kind of support. And the Banyan's philosophy has always been to provide that right kind of support to help the individual understand what it is that their illness means for them and how it is that they can manage that so they can recover. So the idea of the Banyan was always a transit kind of facility, one where residents were rescued, where they went through a recovery phase, and where we ended up rehabilitating them by reintegrating them with families. In fact, the first reintegration happened within a few months of the organisation starting. When we crossed 100 within this 3-bedroomed apartment, space had become a significant issue for us. And we were very lucky that at the time we had the support of the then Chief Minister of Tamil Nadu, who provided us with the grounds on which we were able to develop a 250-bedded facility, which we moved into in 2001. A facility which we call a daycolum meaning home or shelter. Within a daycolum itself, at the moment, we have 179 residents who are going through or undertaking a period of care and recovery through the work that we do. The facility provides a combination of medical intervention, using a psychiatrist, plus social interventions like therapy, like counselling, like work, like access to support services, all combined together to try to help move the individual from illness through to wellness. As women recover and as they make progress, then what we try to do is to help them to be reintegrated with their families. We do this through a process of trial leaves, where they spend increasingly long periods of time away from us and with their families until they are in a position where they can make that move permanent. Over the years, we've dealt with 1,600 such women, rehabilitating around 950 of them with families. Now, just to illustrate that kind of point, I'd like to talk to you a little bit about one particular case, Muthulakshmi. Muthulakshmi is not pictured on any of these pictures, by the way. Muthulakshmi came to the Banyan around 18 months ago. She was referred to us with a combination of mild learning difficulties and a clear case of psychosis. She was very, very cooperative when she came to us, worked very well with our psychologists, our social workers, and our psychiatrist in terms of understanding what her condition was, and made fairly rapid progress. She was able to take on work within the organisation as part of her therapy, and was able to do that completely unsupervised, very cooperatively. Sadly, because of the nature of her illness, she was unable to remember where her family even came from. She expressed in her therapy sessions constantly the need to go home to her brother, really wanted to go back to see him, but had no way of contacting him. As the weeks progressed, as our interventions on her recovery improved, so her memory did, and she was able to access those memories about where her family came from. And eventually, with the help of the local police, we were able to trace her brother to a small town just outside Salem, and to arrange to visit him and to get him to understand the nature of the problem. Now, our social workers do a lot of work with the families in advance of us even trying to get families and residents reunited, because a lot of the problems about reuniting people is the lack of understanding of what the illness actually means. So they did a lot of work with this brother, and eventually we took Muthulakshmi back home. Now, Muthulakshmi was very excited about going home, one of these things that she was really, really keen to do and had been for the last few months. A few miles out, started to get very panicky and really didn't want to leave the comfort of the Banyan. We did a lot of talking with her, a lot of talking with the brother. We eventually got her settled, and she agreed to stay with the reassurance that if something went wrong, she could always come back, which was great. I'm pleased to say 3 months later, with constant phone call follow-ups and so on, she's still doing well, she's still with her brother, and she's now much, much more settled. One of the interesting things I find about Muthulakshmi's case is that it illustrates, for me, just how difficult it is to help people get home. They may well want to go home, but it's so difficult to make that transition happen. And it's only possible thanks to the hard work and dedication of our social workers and their understanding of the issue and their understanding of the family dynamic that allows us to make these transitions happen. So, just a couple of pictures of Adekulum. Why is it that people like Muthulakshmi end up on the streets of Chennai in the first place? Well, one of the key problems that we face is a lack of localized access to care. She lived in a very small town, away from most support systems, even from a general health perspective. But from a psychiatric health point of view, she had no access to care. What that means is that her illness remained undiagnosed, it remained untreated, until it became unmanageable. And once it becomes unmanageable, it's very easy for people to wander off, board buses, board trains, and end up in some of our metros, and therefore a problem on the streets. So about 5 years ago, the Banyan strategy moved from being this crisis intervention, which it always had been, rescuing women off the street and helping them get home, more to thinking about why they were on the streets in the first place. And so we developed a community program that is focused on looking at delivering a solution to this localized access problem. Now, I'd just like to give you a little bit of context to this in terms of where we are in general health terms. In general health terms, there is very good public health policy for mental health across India. The National Mental Health Programme was inaugurated in 1982, devolves its responsibilities down through the state structure, delivered through the district mental health programme at a state level. There are 1,100 crore of rupees, around $220 million, earmarked in the latest 5-year plan to deliver a national mental health programme, which is 10 times the amount of money that was available in the previous 5-year plan. It's designed to operate at a very local level through primary health centres, PHCs. The idea is that you have some kind of issue with your mental health, you go and see your local general practitioner who has sufficient training to diagnose simple problems and be able to diagnose and prescribe medication to help you at a very local level. Sadly, the reality is only 1 in 6 districts across the entirety of India even claims to have a district mental health programme. Within that, GPs are very often hard-pressed. They receive a grand total of 4 days of training to identify mental health problems. 4 days, which if you were a mental health specialist would be a 4-year course, by the way. And very often, medications are supposed to be stocked in local PHCs, but simply aren't available. The doctors don't prescribe them, so they don't order them, so they're not available. So the reality of this is great public health policy and really poor implementation on the ground. So our community mental health programme is designed to try to solve that kind of problem. How do we make the district mental health programme a functioning model, something that can really, really work? And it's all based around our idea that if we can intervene at an early level, detect problems early enough, then we'll prevent crisis from happening and people ending up on the streets of our cities. Our CMHP, Community Mental Health Programme, is based around the Banyan Health Centre in a small village called Kovalam on the east coast. We went there following the tsunami, did a lot of work with the local community to understand what their health needs were, and as a result established the Banyan Health Centre. Now the Banyan Health Centre provides 4 days of general outpatient clinics plus 1 day of a psychiatric outpatient clinic. We currently have 2,500 people registered with us from a general health point of view, about 750 registered from a psychiatric health point of view. Within the facility itself, we also have a 12-bedded inpatient facility for those very chronic cases which can't just be solved with simply a pill and a little bit of social intervention. Our model looks at not only the medical bit, which is how the primary health centres work, but also looks to try to introduce all of the other interventions, the psychosocial interventions, like counselling and therapy and so on, that we use in our crisis intervention centre. All of that's very nice and works reasonably well. We also have supporting that something that is not available through the PHCs, and that is our community team. Our community workers, recruited from the local community, knowing that local community very well, understanding that local community, are our key difference with the way in which the district mental health programme works. What they do is help to increase awareness of the problem in the local area as a whole, but more importantly, spend a lot of time with our patients, getting them to understand their own illnesses, working with families to help them understand what the illnesses mean, working with neighbours so they understand it, which has helped us to ensure that people get care at a local level and don't have to end up leaving the local town that they live. I'd like to illustrate that with a story of Manikandan. Now, Manikandan, when I first met him, I met him in June this year on a routine visit to our health centre. As I went into the organisation, there he was, torn clothing, open wounds, storming around the centre, looking and into every reflective surface in a kind of very manic kind of way, talking to himself aggressively. It was clear that he was unwell. Now, I'm not a mental health professional. My background is financial services. I have absolutely no idea what his illness was, but it was clear that he was unwell. He was actually admitted into our facility as an inpatient at that point. Now, what had happened is that our social worker, our community worker, had spotted him at the local bus stand, begging amongst the passengers in this kind of dishevelled state, clearly behaving erratically. So he approached him, talked to him, found out where he came from. It turned out he came from Sholinganalla, which is not very far from here, not very far from Chennai. So we took him home, talked to his parents and persuaded his parents that this illness that he had could be something we could deal with. So they came to the Banyan Health Centre the following week. Around 3 weeks is all it took of medical intervention, some therapy and some counselling to turn a deranged young man, estranged from his wife, a stranger to his family, into somebody that became a productive member of his family again. He was able to go home in a very, very short period of time. He's now back together with his wife, who understands the nature of his illness and is prepared to work with him. It's a very, very short distance from the bus stand to the streets. And thanks to the intervention of our community workers, we were able to prevent illness turning to tragedy. Now, underpinning all of this, and this is where the theme of the conference comes in, underpinning everything the Banyan does is a care and a desire to help that allows us to spot the problem in the first place and to use it as a key part of our therapy. That's what inspired me to come out. I hope it's a story that has also inspired you. Thank you very much.